Welcome to the Moss Report. Hosted by Dr. Ralph W. Moss, his guest today is author Jane McLelland.
I'm speaking to Jane McLelland, who's the author of the, we could almost say, best-selling book, certainly best-selling in the cancer field, called How to Starve Cancer Without Starving Yourself. And I've enjoyed reading your book, both Kindle and hard copy. By the way, I wanted to be able to underline and all that, so I've reverted to the old school. But for the people who are not familiar with your book and your work, maybe you could narrate for us what your history has been. You were not a cancer scientist originally, so you got into this in the way that many people do. Why don't you tell us a bit about that?
Yes, I was thrust into the world of cancer really not knowing anything about it. In '94 was my first brush with, my first personal brush with cancer. And that was cervical cancer. It had already spread to my lymph nodes. And then my mother got breast cancer for a second time in '96. And she died quite swiftly. And that was a real wake up to me that really the profession wasn't dealing with, they hadn't got the right answers for stage 4. And that it was something that I needed to pay a little bit more attention to. And then it spread to my lungs.
What year was that?
That was in 1999, so quite a long time ago now. And I had a surgery, and then I followed that again with more chemo. I'd already had chemo and radiotherapy the first time, and a hysterectomy, obviously, the first time. And that then meant that my immune system was really in a shocking place for a long time. But I then developed this blood problem, which was myelodysplasia, which can then lead on to leukemia. And I had some new changes in my blood. I had my P53 suddenly was deleted or absent. And I had a lot of other changes that I was so tired. I could hardly walk even from the bathroom to my bed. You know, I was really short of breath. And it was at this point I really knew that I was not looking in a very good place. And I was doing lots of alternative things and adding on things to my conventional treatment when I had the cervical cancer, and I thought I kind of had that under control, but this new one was really behaving in a different way, and I didn't feel like I was on top of that one at all. But my cervical markers throughout that particular time remained normal. They were within normal range, so this was new and different, and that was very scary.
But what was it exactly? I mean, you mentioned about myelodysplasia,
Yeah,
which I think can take many forms and different degrees of severity.
Yeah, and it was related to the therapy that I'd had, the chemo and the radiotherapy, back in '94. Actually, I think the classic timing, I think, is something between 5 to 9 years for having a blood problem as a result of radiotherapy or chemotherapy as therapy. So, and it tends to affect younger people actually more than older people. But I think it was the radiotherapy to my bone marrow, which kind of had been the big problem. I mean, my oncologist was quite clear that she was probably going to kill me with the dosages of treatments that she was giving me. And I think there's a much higher, I think with advanced cancers, they kind of don't expect you to get to the stage where blood disorders happen. And that I certainly felt that she was just trying to buy me a few years, and she probably felt maybe she was, I don't know. I mean, a secondary blood cancer is not something that springs to mind when you're treating somebody, I guess, for cancer.
But was the myelodysplasia a cancer? Was it diagnosed as a cancer?
I didn't actually, well, I didn't want to discuss that with my oncologist at the time. I've discussed it with a hematologist since, who's looked at the slides, who's looked at the deleted P53, which was new, and that you wouldn't get a deleted P53. That only happens in the area where you have a problem. So, and also what was indicative was that in the blood I had this TM2PK test done, which shows that I had aerobic glycolysis, which is a marker for cancer. And that shows that it's doing this abnormal Warburg effect in the blood. So it's fermenting glucose rather than using oxygen. And that was as a result. I mean, I had, you know, the red blood cells were so misshapen. I don't think, when I looked at the slides, actually, it looked like I didn't have any red blood cells that were normally shaped. So they weren't picking up oxygen and delivering that to my tissue. So it's no wonder I was so exhausted. I felt, you know, it was really really bad in terms of,
But
you
know, what you're speaking about would be a live blood cell test. Would that be correct?
Yeah, which is not on its own a diagnostic tool. It is indicative of a problem. And in fact, actually, you know, most cancer patients will have stacking of their red blood cells, which is known as rouleau, but this was different. This was beyond that. So later on, it developed, and I had misshapen red blood cells. So it was not just the stacking of the red blood cells, it was that was sticking together. That was kind of a primary, that happened before the red blood cells then became misshapen. I didn't put that slide in the book because it was so fuzzy. When he took a picture of it, and the picture he gave me was so fuzzy, it wouldn't have come out particularly well in the book. But the red blood cells were all jagged, and they weren't round. They didn't have the kind of normal look to them. Okay.
So this was done, though, by a complementary physician? I mean, this was not a test that normally would be given.
This is a doctor. He's an oncology, complementary oncologist, if you know what I mean. So he's he deals with cancer patients all the time. That's his primary field.
Could you tell us who that was?
Yeah, Dr. Julian Kenyon down in Winchester. Yeah, in England.
I have visited with him there.
Okay. Yeah.
So basically, you were in bad shape. Probably had some sort of cancer, some sort of precancerous or cancerous condition going on in your blood.
Yeah.
And what did you do then?
Well, I actually went to see another, because I had the only way for me to really get hold of information was to quiz doctors, was to look through research papers. So because the internet was very sparse back then in terms of information. So I was gleaning a lot of information. I had several doctors who I had looking after me. I didn't just rely on one. So I went to see Dr. Calabou. Do you know Dr. Etienne Calabou?
I do.
Yeah, lovely guy. So I went to see him, and I took with me a whole bunch of research papers on some drugs and things that I'd been looking into. And the first one I asked him about was an old antiplatelet drug called diprytamol. And this had effects on the blood. And I felt that this would be useful. It was an antiplatelet drug. And because I'd previously had all these red blood cells sticking together, and I think that had led to this sort of lack of oxygen, which can then promote cancer. Inflammation and a lack of oxygen are key promoters for cancer. And I felt that sort of unsticking the blood for a start would be a good thing. And then it had also been shown to have all these anti-cancer effects. It's actually very good at stopping growth factors, MMPs in particular. And this was it had been shown in melanoma patients to prevent stage 4 from progressing. I didn't know why at the time, but it has an effect. It has quite a strong effect on fat, as well as blocking nucleoside transport. And nucleosides are little chunks of DNA which the cancer cells will actually use to sort of remake daughter cells. So they'll sort of continually give birth to daughter cells. And these little nucleoside chunks are quite hard for cancer cells to make. So if they can scoop them up and just take them in from the external environment, they will do so. And this, what diprytamol does is it's a nucleoside transport inhibitor. So it was stopping the cancer cells from taking up proteins, if you like, that make the DNA. So that to me seemed like it seemed to have such, and I looked at other research as well, which showed that diprytamol had, had effects not just in melanoma, but in blood cancers as well, potentially. So I just felt it was something I needed to put into my mix.
So was this laboratory research or was it clinical research? Was it research in human beings?
This was, it was a report in the Lancet. The melanoma case was a report in the Lancet, a lady called Elizabeth or Betty Rhodes at Kingston Hospital, who had been looking at these melanoma patients. But it was just a write-up in the Lancet back in the 1980s. Actually, this was stuff that had gone way back to the 1980s. But I had been reading a magazine called The Townsend Letter, which you probably are very familiar with. I'm sure you've contributed to many times. So this is it was just a letter in there talking about diprytamol that kind of alerted me to it, and then led me to sort of looking into the research back in the 1980s. But it seemed to be potentially, a very exciting addition to me, and I couldn't see why just adding this drug in, if it was low toxicity, would be such a problem. So I added that in, and then I came across some research about statins. So I added the statins in. So I used lovastatin, which was pretty much, though I don't think there were many statins on the market back then. So lovastatin was my choice. I think there were a few statins, but they decided Life Extension had done some research to show that that was better than other statins. So I did that. And then the etodolac was a non-steroidal anti-inflammatory drug, which has been shown to cause apoptosis, which is just cell death of the cancer cells on its own, but was 5 times more effective when you added the statin in. Because actually what a statin does is it kind of it helps to lower glutathione a little bit. So that makes the cell a little bit more vulnerable to being killed off. So that's that to me seemed like a good idea. So you do a double hit with both the statin and the non-steroidal at the same time.
So you were really exploring the world of repurposed drugs, right? I mean, you were taking drugs that were originally approved for other indications, and based upon scientific work, you were then applying that, drawing conclusions from that scientific work, and then getting doctors to prescribe these drugs for you. Am I correct?
That's absolutely correct. And yes, to me, it seemed crazy that there was all this research on the natural side. There was all the stuff on chemo and new drugs, but there was a whole area in the middle that seemed to be ignored, which was sort of somewhere in between the two. So old drugs with very low toxicity that seemed to have all these anti-cancer effects, because in the old days when they made the drugs, they weren't targeted like they are today. They made them to sort of do a job, but actually they had other wide-ranging effects at the same time. So they were known as dirty drugs, the old drugs, because they affected different organs in the body, many different organs, and not just targeting one specific location, which is what most drug companies try and do nowadays. They try and make more targeted drugs. So the old drugs had far more pleiotropic, all these sort of a wide-ranging effect on the body, and the side effect of which, in some cases, is to have these huge anti-cancer effects. And the whole starving element it dawned on me as I continued to sort of research that starving the cancer cell seemed to be the key, not just for killing off the fast dividing cell, which is very voraciously hungry, but also the stem cell, which is a slower dividing cell, but also, it does need nutrients, and it behaves, it swells up and it behaves in a different way to normal cells. So, and I didn't understand much about the cancer stem cell back then, but I've gradually, particularly as I started to write my book, things became an awful lot clearer as to the reasons why things worked that I did. And I was able to piece it back together, and the jigsaw was sort of falling into place with the way it started, the way everything sort of pieced itself together. So I was able to put together my metro map in my book, which I think people find enormously useful. It's not die hard fast, this is it kind of map of how to starve your cancer. There are other pathways that lead into some of those other, bigger pathways. But what I've tried to do is keep to key routes, if you know what I mean, key access routes for the cancer stem cell to grab either glucose, glutamine, which is the protein, or fatty acids. And it'll use all three. If it can't get hold of one, it'll get hold of another. But most cancer cells will use all three to feed itself, but there will be a sort of a bias as to what it tends to like. And I've noticed that.
So now we've evolved or devolved from 1924 when Otto Warburg basically showed that cancer cells have a faulty metabolism, that's to say a faulty way or a different way of generating energy, that they revert, even in the presence of oxygen, they revert to the fermentation of glucose rather than the oxidation of glucose, the normal respiration of cells, right? So I think for a long time, many people, myself included, thought that this was a much simpler picture. I think Otto Warburg thought it was a much simpler picture, namely that if you could control the amount of glucose in the bloodstream, you could starve the cancer, or at least hinder the growth of the cancer. And about, as you say in your book, about 90% of cancers do have a high rate of glucose consumption, at least double that of the normal cells. So what's wrong with that theory?
Well, the problem with that theory is that you also get an upregulation of the mitochondria. So you get new mitochondria being created in the cancer stem cells to sort of compensate, so that when energy levels are not sufficient, and when the cancer is actually creating its daughter cells and it's creating these new blood vessels around it, the ones that are sort of the closer to the surface cancer cells actually they thrive on oxygen as well as not being in an oxygenated environment. And this is where you get this mitochondrial biogenesis. So you get new mitochondria, and you get an upregulation of the normal OXPHOS, the ATP OXPHOS production. So and there's a sort of compensatory. So where you get not enough, where you've got glycolysis going on, you get less of the OXPHOS, but normally there's a sort of a balance between. There tends to be an energy balance depending on the position of the cancer, the amount of oxygen in the environment. The cancer cell is very adaptable, and that's the problem with it, is that it is able to adapt, not just its ability to use either oxygen or not use oxygen. it can also use all sorts of different energy substrates. So that, the glucose, the fatty acids, or the glutamine, and the glutamine and the glucose again tend to be sort of interchangeable a little bit, but it's a far more complicated picture than Otto Warburg painted, and it does mean, and that's why we don't necessarily get the results with just cutting glucose out of the diet. Just doesn't give it, although it worked quite well for me, because I was doing that with my cervical cancer, which is more glucose driven. That cancer is far more glucose driven than the blood disorder, which is more glutamine driven. So leukemias, generally speaking, are driven more, although they do have this glycolysis component, they do have a much higher demand for amino acids, which is where the diprytamol, I think, was particularly useful. In fact, in 2014, I have noticed that somebody's patented the combination of diprytamol and a statin as a treatment for blood cancers. So I was ahead of her, but
you didn't get the patent.
I didn't get the patent, no, and I'm not sure, to be honest, what good that would do anyway. How do you enforce that? I don't know. Anyway, so
Memorial Sloan Kettering has a patent on a glutamine PET scan.
Right.
They haven't brought it out yet. Craig Thompson, president of Memorial Sloan Kettering, invented a glutamine PET scan. But how do you block glutamine? You talk about starving cancer, glutamine being the second most prevalent source of nutrient for cancer cells. How do you block it? It's the most abundant free amino acid in the body.
Well, that is the issue, is that you can't block glutamine itself. What you can block is its transport into the cancer cell, and you can block some of the glutamate, some of the glutaminase that gets created as a result of the cancer cell breaking it down. So it's the glutaminolysis, the breaking down of the glutamine. You can't stop glutamine being in the body. You can't block it. There's no point really getting, people do cut down on their protein, and I think it does help if you have a very protein driven cancer to be reducing the amount of protein that you have in your diet. But on the other, you don't want to have too much glutamine in your system. You want to be able to control what you have, but it's blocking the glutamine into the cancer cell that's the key here. And to block glutamine, there are some very exciting drugs out there which have been around for a long time. You have to look at the treatment of acute lymphoblastic leukemia for kids, and they have asparaginase, which is very similar, and that helps to block the uptake of asparagine, which is another type. It's actually very similar to glutamine. And when they brought that in the it's quite old, that drug. 60s. I think they bought it in the 60s, but it completely turned the kids were dying of that all the time, but it changed the survival statistics to something like 90% from being about 20%. So it had a massive effect, just blocking that glutamine. And again,
you mean asparagine?
Asparagine, yeah. And it just had this effect of blocking that particular amino acid. And it just goes to prove that, if you block the right substrate that the cancer really feeds on, then you will actually convert it back to, you have the ability to sort of put the blockers on its growth. So
yes, it's a beautiful concept.
Yeah.
But what do you think about Dr. Thomas Seyfried, who wrote the wonderful jacket quote for you, called your book A Monumental Accomplishment? But I had an email from him just this week in which he said that basically they can destroy all the cancer cells that they're looking at with a combination of metformin to block the glucose and a drug called DON, an
Done.
old drug,
Yeah.
which blocks glutamine
Glutamine.
uptake. And in his laboratory in Boston College,
Yeah.
they're using just those two drugs, and they're getting, again, it's laboratory work, so we can't assume that this is going to work
On mice.
probably in mice, yes.
Yeah.
So what do you think about that? What do you think about this DON and about the idea that you could, even though it's probably true what you say, that some cancers do use fatty acids as a fuel source, but
Yeah.
the overwhelming majority of them would be
Yeah.
covered by the glucose and the
The glutamine.
glutamine.
Yeah. Well, I think that the Don, being an old drug, um, it was shown to cause all sorts of issues because it would deplete glutamine. It would deplete your glutamine is quite necessary in your gut and also in your brain. It worries me about the potential side effects or long-term cognitive or leaky gut that you might get as a result of taking Don. I can see the benefits of possibly trying it, but I think that's to me, I applaud his efforts, and I think that's terrific that he's doing the work. But in humans, I have the concern that it would be too toxic as an approach. I think there are glutaminase inhibitors, the BPTES and the CB839 are two glutaminase inhibitors that I feel should be used pretty much with every cancer, because cancer will either use glucose or it'll use glutamine. Fatty acids also are more prevalent in some cancers, like melanomas and prostate cancer are very fatty driven. And so are some of the hormonal cancers. But there is always the use of glucose and glutamine. And if we added the glutaminase inhibitors like BPTES, made them, at the moment they're a little bit toxic, but these are potentially, I really feel that if we just got those to be less toxic, things like triple negative breast cancer, which does feed on glutamine quite heavily, that's one of the worst cancers. You could really strongly affect the survival of people, and it's just getting the right cocktail. And the problem with Siegfried is that he's only using 2 drugs there, and I think that's really missing the point, because with my metronome, you can see that there are there are many pathways. Metformin hits an awful lot of those pathways, and Don being as effective, it is a very effective glutamine inhibitor, but it just worries me that it's too effective. That's the problem. And I feel that he misses a trick by not adding anything into, because he feels that with the fatty acid oxidation, then you get either glutaminolysis or you get glycolysis happening. And if you just block those two, then that's the end product. And the fatty acid oxidation is kind of before that, and he doesn't use anything to help block the fatty acid input, and I think that's a mistake personally. I feel you can make the whole thing far less toxic with a bigger combination and less toxicity using more drugs in a lesser dose. So yeah, I applaud his efforts, but personally, even if I got a glutamine-driven GBM, I would be wary. But surely,
Meaning
yeah,
brain cancer, which
yeah,
is his topic, his area of research. Tell us about Care Oncology Clinic. They seem to
yeah.
have come along somewhat after you started pioneering the use of the repurposed drugs for cancer.
Yeah, I was utterly gobsmacked that there was a clinic actually finally using all of these drugs. So yeah, I was delighted by that to find, and they've now started a clinic in the US as well, in South Dakota. So I am absolutely thrilled to see that this is happening, and patients can actually access more than just, metformin, and that they can get 4 repurposed drugs. So again, this is targeting more pathways, which I think is key, because
So that
cancer
would be
is complex.
metformin and doxycycline and a statin and
Yes.
mebendazole, right?
Yes, and they also have a non-steroidal, which they sometimes prescribe to people as well.
An NSAID, painkiller, anti-inflammatory, I should say.
Yes, anti-inflammatory. So
which of those, and I could ask them this directly, but to your knowledge, which of those 4 drugs or 5 drugs would block glutamine uptake? I'm not clear on that.
no, you see, metformin has an effect on mTOR, but it doesn't. There doesn't seem to be. To me, there's a whole area of that seems to be missing with that combination. I think it goes to some degree. It goes. It does do a very good job, but to me, I feel it's still missing some crucial pieces, and particularly with this abnormal uptake that the cancer cell starts to do as it progresses. It uses autophagy to kind of feed itself, and people get a bit confused about autophagy, because in the healthy person, this can be a good thing. It can help clear out your senescent cells and just, revitalize you a little bit, revitalize your immune system. But with what worries me is that, that the care oncology are not blocking this autophagy process, which becomes more prevalent as a cancer progresses and becomes more aggressive. And particularly pancreatic cancer is a case in point, which uses this autophagy process from the word go. So it uses something called macropinocytosis to sort of engulf extracellular glutamine and glucose.
It's that the body eating itself, basically.
Yes.
I mean, the cancer eating the body.
Yes, it does. It does. And this is why you get weight loss. This is why you get, and it's able to still feed itself even when you're starving, and this is the problem, is that you can sometimes almost trigger autophagy, because the cell will react. If there is a lack of nutrients in the area, it sends out signals to sort of break down fat and protein in nearby tissues.
But it's also a healthy thing, as you say, in a person whose cancer is not using that technique.
Exactly.
It cleans out the cells
after
about 12 hours of not eating. So
intermittent fasting is a good thing.
Yes,
it's a good thing. Pulsing a bit of intermittent fasting, I think, is a good idea.
So what's next for Jane McLelland? What do you have? Any projects online?
I will be doing I'll probably make some video courses just to try and explain why cancer behaves in certain ways, and maybe go into try and work out more the metabolic phenotypes of different individual cancers as to how they feed, and maybe look at different, because, there's a whole armory of treatments that are not used by traditional oncology at the moment that could be employed by cancer patients. So there's so online, probably some video courses, maybe some. I certainly have to update my current book. I'm going to relaunch that probably towards the end of. I'm going to wait until the end of next year, I think, to relaunch that.
Relaunch what? What is that? Relaunch what?
Well, just my current book, but with some added extras in there. So things that will help target some of those pathways, as well as the stuff that I've mentioned. There's been some more research on things, and there will be more research coming out as well. The longer you wait, the more these things are revealed. So and I want to give people the best chance, but that there is the information already in my Facebook group,
which is how do people find you there?
Okay, it's a bit of a long name, but you start with my name, which is Jane McLelland. That's McLelland. Everybody spells it wrong. Jane McLelland, Off-Label Drugs for Cancer. So a bit of a long name.
Good.
And it's a closed group, which means, you only find it if you really are looking.
Are you still maintaining your starve or how to starve cancer Facebook page? Didn't you have that?
I have a How to Starve Cancer. That's more my book page, but on there I do throw articles specifically about starving the cancer. The other group is really more about looking at other drugs, but the How to Starve Cancer is very much more focused on trying to find different approaches to actually starve the actual cancer cell.
Well, thank you so much, Jane, for talking to us today.
Pleasure, Ralph.
It's nice to finally meet you, as it were.
Yeah.
We've spoken on we've talked a lot, and of course I learned about you through the Life Extension Foundation seminar that we had for the Scientific Advisory Board. So it's fascinating work. You've done an amazing thing in bringing to public attention the fact that cancers have to feed themselves and get rid of their waste materials, and this gives us an opening for how to kill cancers, basically.
Yeah.
So you've really raised the public awareness and the level of the dialogue on this. So thank you.
Okay, pleasure.
Great talking to you. Thank you for listening to The Moss Report. Visit our website at themossreport.com and subscribe for new episodes straight to your inbox. For your cancer treatment options and phone consultations with Dr. Moss, please visit mossreports.com.